Thank you so much. My slides are visible?
Yes.
All right. Thank you so much for the opportunity to Team Yossi for this platform that is with AIOS. So moving in straight away, what's new in the field of cataract? It's an extremely vast field. I've tried to incorporate all that is there. So moving ahead, so first of all, we need to see what the timeline is. So we had started in eye surgery from the naked eye couching from the Sushrutas time. Then we moved on to torchlight, followed by a slit lamp examination, then high magnification. And now we are in the age where 3D surgery is the norm. That is the latest in cataract surgery. So I would take this topic according to the steps of surgery in a cataract. What are the advancements that are happening in each step of the surgery? So first of all, mapping the eye. Now, I've been a sportsman myself, so I'm dividing it into two corners, just like boxing. You have the blue corner and the red corner. In the blue corner, we have the Artivo system from Zeiss, which is a 55-inch 4K system. And in the red corner, we have the Ingenuity from Alcon. Now, the Alcon Ingenuity came in before the Artivo. The Artivo is relatively new, and it is only present in a few centers in the country at the moment. So the advantages that we have of this 3D surgery are that the magnification is there, and it's high magnification without any loss of resolution. The depth perception is enhanced manifold. The next point is extremely important. Operating is at a low illumination, just 20 to 30% of an optical microscope, which is very, very comfortable for a patient, especially when you're operating a patient in topical anesthesia. Also, it adds a new dimension in training because whoever's in your OR is getting the same view as you are getting. It's not like you're getting a view from the tunnel. Everybody around is being able to see at the depth. And we all know in cataract surgery, depth perception is extremely important. Next advancement in cataract is the intraoperative OCT. Again, Zeiss came up with one first, then Hextard came in, and now even Lumera has jumped in with the intraoperative OCT. This has more of an advantage in retina, but in cataract, it really, really helps in us making the perfect incision. Now, the incision, as we know, should be triplanar, and looking at the OCT from the cornea, we're able to make that incision properly. Sticking to incisions only, the next step in cataract surgery, of course, after mapping the eye, is making the incision. What we have in the latest arsenal is the video and image guided surgery. Now, how this works is that if you see these two arrows that are made, this overlay of the image, it guides you exactly where you're supposed to be making your incision. So what you can do in this is you make your incision according to the way you want to correct an astigmatism. And it is going to be extremely precise because you will have the mapping of the entire 180 degrees of the eye. Not just the incision, of course, the Virion system is extremely helpful in implanting toric IOLs also to exactly the degree that we need to implant it in. We know that if the alignment is not proper and the IOL shifts places, then of course we lose the toricity that is there in the lens. So corneal astigmatism, it has been reported by Hale W.J. in the Journal of Cataract and Refractive Surgery that it is reproducible corneal entry and the arcuate incisions also that help in reducing the astigmatism. Now, these things are there on your femtosecond platforms, and now with the help of this intraoperative OCT as well, an early wow factor that's reduced phaco power and corneal edema is caused when we use this. So, how do you do the femtosecond laser arcuate incisions that reduce the astigmatism? So, first of all, it's an image-guided surgical planning with 3D visualization. It gives you a real-time corneal thickness. It's a computer-programmed incision which gives you a percentage depth that you're supposed to go at, incision length, and 3D visualization of incision placement. There are many nomograms that are there. The one that we used to use, the one that is widely used, the Donenfeld nomogram. Now, of course, we have the modified Donenfeld nomogram also, which you're supposed to use it according to the amount of astigmatism that is there. The incisions are also titrables. That means they're adjustable during surgical procedures and adjustable post-op at the slit lamp as well. So the next step of surgery, capsular access. Now, this is a field where a lot of enhancement and a lot of advancement has happened. Again, in the blue corner, we have the Catalyst system, and in the red corner, we have the LensX system. These are the main two systems, and I've been lucky enough. to have the opportunity at Narayan Nethralaya to be using both. So I can share your experience of both of them. So the thing with the catalyst, first of all, is that catalyst makes your rhexis extremely fast. Within 1.5 seconds, the rhexis is made. Whereas the Lensex takes a little more time in making the rhexis. But if you're doing the entire procedure with it, that is, you're making the rhexis as well as making your chops and your incisions, then both of them do it at the exactly same time. So also in capsular rhexis, again, the image guided system, as I told earlier about the Virion, that also, if you don't have a femtosecond and you have just a Virion, then this Virion, you can map it according to whatever size you want, 4.5, 5, 5.5 millimeters, and it will give you an overlay. So you will know exactly where you're supposed to be inside the guided marks where you can make your rhexis. Just when we thought that image guided was enough and femtosecond was too expensive, in came into the market the Zepto cataract surgery that has been covered in the last talk as well. So how this works is that it has a 4 millisecond energy, very short energy pulse, and it uses a vacuum. So you're supposed to place it inside the eye. It is a little cumbersome. You do need an assistant to do it with you simultaneously. So when you place it inside the eye, that person has to have the vacuum ready. So it has to be a coordinated thing. So the only downside I would say to the Zepto, although it is extremely economical when you compare it to the femto technology, is that you need a very good assistant to be with you who does it at exactly the same time that you guide the person to do it, because it has an electrical impulse. The moment it reaches the capsule is the moment that the vacuum has to be released. Okay, so the new boy on the blocks is the capsule laser. It has not yet come in India. So all the other things that I mentioned before, you needed something that was a separate machine. For the femto, you need a huge machine. For the Zepto, again. Here we have a capsule laser which can actually be fitted on your microscope. And once it is fitted on the microscope, it takes 1/3 of a second in the capsule laser to actually make this rhexis. And it is completely comparable to the one that is made on the femto. So it was introduced back in 2019 in the USA. And this is again making ground, and it will soon be available in the Indian market. Coming to the next step, that is the nucleus fragmentation. So we had the conventional cataract surgery in which you're supposed to either make a trench and then separate your cataract, make fragments of it, or do a direct job by embedding your tip. Then we moved on to the laser assisted cataract surgery. That was the femtosecond. And just when we thought that the laser assisted cataract surgery was enough, there came the MyLoop from Zeiss. So how does the MyLoop from Zeiss help? The MyLoop from Zeiss, you're supposed to basically take it around the nucleus. It has a lot of learning curve. It's a pen-like device. It has zero energy length fragmentation. That's where it helps. It's extremely helpful in hard cataracts. It has a full thickness length fragmentation at any grade of cataract is what the company claims. It's engineered to minimize capsular stress and phaco power that is done when we're doing a chopping. It uses micro thin, super elastic and self-expanding nanotale filament technology. So this does have a learning curve, but once you master it, it becomes easy. So again, this is a Zeiss product. It's an expensive product. So what we also have in the market now.
Rohan, can you just conclude your talk?
Yes, I'll just conclude it. So what we also have is the phaco pre-choppers. Now these pre-choppers can be used. They're extremely economical. The intraocular lenses, we have the Alcon. We had the Panoptic since a long time. Now we also have the Toric that we were waiting for a long time. Now the AMO has come in with this thickness eye hands technology, which gives you distance vision and intermediate vision without any rings that are there. The problem with the rings is gone with this eye hands IOL. Coming to the last part of my talk, that is planning. I think that's the most important part in cataract surgery, and very important part is biometry, precision and accuracy in biometry. And I'll tell you why. The reason is that claims relating to biometry errors and wrong intraocular lens power were the second most frequent causes of claims and results in payment of damages in 62% of closed cases in the UK. This has been published in the British Journal of Ophthalmology. So stressing upon your biometry, I mean, the more you stress, the less it is. So the swept source OCT is the latest kid on the blocks. Anterion, as we know, it's a single modal machine. It has the cataract, corneal, imaging, as well as the metrics apps all in one machine. So eye trace, again, aberrometry. This has a new thing that is there. We already knew that the modular transfer function and point spread function was there. What this now has is something called a dysfunctional lens index. So what it tells you is it gives you aberrations separately, whether they're coming from the cornea or from the lens. So there was no machine till now that could give you whether the aberrations are coming from the cornea or the lens. That helps us in choosing when to go ahead with the cataract surgery. Now, hitting the target with the IOL, we've seen this chart everywhere that when to use what IOL formula. The latest formulas are the Olsen-C formula. We know this is according to the effective lens position. It takes into consideration something called a C constant. Then the Hill RBF formula, which is an AI-based formula. This has basically what it has done is that the SRK formula gave us a 0.5 diopter accuracy in 78% of the cases. Now with the Hill RBF and the Barrett Universal 2 formula, we have achieved a 91% accuracy of 0.5 diopter or within in our post-op cases. The Super LADAS formula again is a self-learning artificial intelligence formula that is also coming in to our markets now. And looking into the future is the Kane formula that is again just released about 6 to 8 months ago. This is another formula based on the AI platform. I'll conclude my talk saying that it is not the strongest of the species that survives, nor the most intelligent, but one that is the most responsive to change. These are the words of Charles Darwin. And evolution, as we can see due to the pandemic, how our ears are probably going to be coming out if we continue wearing these masks. Also, I'll take this opportunity to invite everybody to this talk that we're having tomorrow on the Youthful IRSI chapter. It's the Guru Mantra Smart Investment as an Ophthalmologist. And this is our QR code. We can all take a screenshot of this and we can log in tomorrow. It's a monthly thing. So it's going to be happening every month. Thank you so much for the opportunity.
Thank you, Rohan, for that excellent